Good morning, distinguished colleagues. I'm glad to welcome you at the Eurasian Society of Therapists meeting. For some people, it's morning. For some people, it's already midday. During the next half an hour, we will be presenting together with Professor Lopatin and Professor Ovchinnikov. We'll be talking about a very important professional problem, that is heart failure with preserved ejection fraction, HFpEF. Among different agenda of this Congress, our symposium is one of the meetings translated into English. That is why the problem is very relevant, and I'm very glad that we can discuss different issues of this problem. As for this symposium, it has some peculiarities. We're not going to discuss just the diagnosis, treatment of HFpEF, but also we'll pay attention to the issues of pathogenesis, the role of different atrium of heart, and Chambers will be talking about the ejection fraction, what kind of therapy can be used, how to treat HFpEF. I hope this symposium will be very interesting, and with your permission, I will start. Well, you can see the theme of my presentation, evolution of ideas about the pathogenesis and treatment options for heart failure with preserved ejection fraction. Well, as you can see here, in speaking of HFpEF, it occurs even more often than other types of heart failure with reduced ejection fraction. Well, this figure, 53%, is not final, and we can also see that the figure will continue to grow, and in Russia, that means 6 to 8 million people with heart failure who have preserved ejection fraction. Well, here you can see the way it looks like in these pictures. This man on the left, well, this is not a 30-year-old picture, but nevertheless, it characterizes the type of heart failure, male, average age, which has a history of hypertension, usually untreated, ischemic heart disease, myocardial infarction, and then everything goes according to the typical scenario, the reduction of the ejection fraction, then the clinical manifestations occur, shortness of breath, weakness, edema, and now the prognosis is not very good. The most common reason of this form is ischemic disease, cardiosclerosis, and any damage to the heart muscle, like due to chemotherapy or inflammation or unknown etiology can occur. But the most important thing is that myocardium is involved. And of course, there are more patients like that with this phenotype, heart failure with preserved ejection fraction. You can see a woman on the right, which is an elderly patient. Well, usually this woman has weakness, especially when she does any physical exercise. Well, the patient, for example, leaves the entryway of her apartment house and she had to sit down to take a breath. And there are also lots of comorbid conditions that such people usually have. And sometimes they're not just comorbid, they may be the major reasons for development of this kind of heart failure: diabetes mellitus, hypertension, hypertrophy, renal insufficiency. Well, there is a question why there are such a bouquet of diseases. In fact, all these diseases are combined into one category, pro-inflammatory conditions, and we will talk about that later. But right now, I would like to show you several slides which are not new, and this is just the general scheme how this type of heart failure is being formed. One of the concepts stipulates that it doesn't matter whether it's preserved or reduced ejection fraction, but you can see the trajectory of development according to these authors. What events occur if nothing happens? Step by step, the patient moves this way. The ejection fraction is preserved, but due to other diastolic problems, well, you can see the severity of decompensation, and this is the formation of this kind of heart failure. But there are also different thresholds and different diseases that occur. First of all, the coronary syndrome, which any time can move in a different direction, and we can see there will be the reduction of the ejection fraction. The process will accelerate, and finally it can lead to the systolic dysfunction and the heart failure with reduced ejection fraction. Obviously, there are protective mechanisms that the organism involves, modifiers of the disease, such as female age, hypertension, hypertrophy, diabetes, aerobic burden, that basically have an impact on the coronary syndrome, and the patient moves along the trajectory of the development of diastolic dysfunction. It's a rather complex scheme. The situation has changed over the last several years when we got a clear understanding of a different mechanism of development of this clinical phenotype, but no ejection fraction, like, for example, cardiomyocyte, remodeling, etc. And you can see these microvessel inflammations of low intensity, which can be accompanied by obesity, hypertrophy, lead to the situation when there is no increase in the volume of blood. There are other processes. The ventricular wall is getting thicker. There is concentric remodeling. That means additional efforts, the diastolic infilling of the chamber, the development of venous hypertension, and obviously the lymph accumulation in the lung tissue, which changes the transportation function, thus resulting in ischemia. Hence, the patient has a shortness of breath. And now we look at this problem from a totally different angle. It is important to notice that there are compensatory mechanisms, as you can see here, cardiomyocytes, and you can see the PAC is activated and aldosterone is increased, and you can see that there is no need to accelerate this process. So these systems do exist, but they're not very manifested, and this has a direct impact on the opportunities of the pathogenetic impact on the course of the disease. As you can see, neurohumoral hormones are being involved, and it's the neurohumoral model, and the use of neurohumoral modulators is not effective here, like in case of the diastolic form. So there should be other ways to have an impact on the myocardium fibrosis, on inflammation, and this is a key change in the treatment of such patients. To sum up, we can say that there are three pathognomonic triggers: the type of the heart phenotype, myocardial damage, usually the left ventricle, and there is a spiral, the compensatory reaction, neurohumoral activation and remodeling, and as a result of it, the process is being accelerated. It leads to new problems and excessive neurohumoral activation, as you can see it here, especially when sartans, beta blockers are used. Well, the heart phenotype, unlike the heart phenotype, the diastolic dysfunction usually falls into the category of the systemic phenotype. The total heart damage, as you can see it here, and microinflammations through fibrosis leads to the reduction of the heart function, and there is a systemic phenotype of the inefficiency of the use of inhibitors, sartans, and other modulators. It should be noted that in modern conditions, this phenotype represents a significant interest, and has more protagonists. Well, of course, as for treatment of heart failure with preserved ejection fraction, there are ESC guidelines on diagnosis and treatment of HFpEF. Well, and you can see here, it hasn't been proven that any treatment reduces mortality and mobility in patients with HFrEF, although, well, diuretics can play some particular role here. But as for impacting the mechanisms of the development of the disease, well, we do not have a significant ability to have such an impact. And here you can see our program of action. First, we must confirm heart failure. That's the first step. Then the phenotype, like preserved ejection fraction, that's the second step. Maybe my colleague will be talking about this in detail. Stage 3, cardiac phenotyping, and stage 4, non-cardiac phenotyping, when we assess the entire range of different aspects, such as lungs, the molecular level assessment of the genetic traits, etc. That's a very complex problem. And in combination with all these factors, we can identify those patients with HFpEF. That's a personalized approach. Here you can see that there are key parameters of the major phenotypes of HFpEF, like hypertension with involvement of the left ventricular vessels, metabolic problems, and advanced age. That's a separate story, and a particular one, because as for fibrosis, we can use drugs to control it, but as for inflammation here, the situation is much more complex. Hypertrophy, hypertension, and diabetes are the major reasons for the development of HFpEF. As you can see it here, it can occur in 55 to 90% of cases. And again, you can see we should manage patients at the outpatient stage by using specific drugs that can have an impact on all these comorbid conditions. The first phenotype of patients, as you can see it here, these are patients with hypertension. Hypertrophy is a very important factor, but it also occurs in other types of the disease. The so-called phenotype of the deficiency of the sodium uretic peptide. Well, you can see it here. There is a major problem, and patients usually do not have a manifested stress with HFpEF. And again, you can see it here. It can have an impact on the wall of the ventricle, but nevertheless, you can see as for BNP, brain natriuretic peptide, well, you can see patients with HFpEF lead to the low ejection of such a substance as cGMP, cyclic guanosine monophosphate. And of course, it's important for the normal functioning of the heart per se. It is important to preserve this hormone so that we could prevent the development of this chain of events. And of course, ARNI can block the process of degradation of BNP, and it can lead to the activation of this receptor and the entire pathway. It's very important to have the abundance of this hormone. It can lead to the change in the morphology process, prevent hypertrophy, and of course the metabolic aspects should be taken into account, namely the ability to work and to preserve the renal function. Here is another study, Paragon NF, in 2019. And again, you can see some of the results here. The study is already over. You can see the curves departed. And nevertheless, you can see that the confidence interval is 95%. And also you can see even if the primary endpoint is not achieved, for example, such as the quality of life, the ability to work, to exercise, everything was quite positive in terms of performance status. We can see as for the renal function, the results are positive, but there are a lot of nuances. And you can see the analysis has shown that there is a category of patients with the ejection fraction of left ventricle less than 57. In this case, we can talk about the positive result. Oh, sorry, these were the patients with the ejection fraction of left ventricle less more than 45. And you can see up to 62%, well, low positive, but more than 62%, the results were negative. Well, so more than 60%. In this case, well, it's a kind of vicious circle. I think that my colleague will comment on this, why this is happening. Going back to why we got these results, and there is an analysis conducted. Again, there was the prevalent phenotype of the deficiency of hypertrophy. The patients had no hypertension, and again, this phenotype was not prevalent. So hence the result. There are some other minor things. The sub-analysis of Paragon and F has shown that we could get the reliable effect. Of course, this has an impact on myocardial fibrosis, and again, the combination of specific drugs can lead to the positive effect, such as spironolactone. And again, you can see we can use MRA, mineral corticoid receptor antagonist, and this can be in addition to the baseline therapy. Well, this is a post hoc analysis that has shown that sometimes there may be a high level of NT-proBNP, and in this case, for example, it can be higher than 360 milligrams. Some countries had this particular indication, and of course, this has a link to the prognosis. And once again, NT-proBNP means that the patient has a substrate and the patient can achieve some particular effect regardless of the phenotype. We should just have an impact on the substrate. And again, you can see the major profiles of the patients for administering ARNI. Again, women with spironolactone in anamnesis, also patients with HFrEF who have hemodynamic or neurohormone surges, and another second phenotype is cardiometabolic phenotype of HFrEF, and here the use of drugs that may have an impact on inflammation is very important. Here is the classical scheme. We move from comorbid conditions, the systemic inflammation and multi-organ failure, and also when vasculature and kidneys are involved, like C-reactive protein, interleukin-1, GDF-15 are responsible for the transmission of the signal, and here there may be a negative effect in terms of cardiomyocytes, well, the reduction of PKG, and also you can see that there might be excessive fibroblasts and collagen production. Altogether, this leads to the chamber rigidity, and then we have this clinical picture. So anti-fibrotic, anti-inflammatory treatment is indicated here, and we have different range of drugs, and here we can achieve quite good results in this category of patients, and later there will be a special presentation on this issue. We have quite good results. As for other aspects, just in a nutshell, well, the phenotype with the erective or mixed form of pulmonary hypertension, the high pressure in the left atrium, venous hypertension. Again, the left departments lead to the increase of the right ventricle. The renal component is involved, and of course, here we need to break this chain using blockers of endothelial receptors or prostacyclin analogs. For us, it's important not just to block this process, but also to change the pressure in the left atrium. And again, you can see that phosphodiesterase 5 inhibitor or sildenafil citrate in patients with heart failure with preserved ejection fraction and combined pre- and post-capillary pulmonary hypertension led to positive results, as it has been shown by a range of different studies conducted in our center. The pulmonary artery pressure goes down. That's very important in this situation, and especially for patients with mixed forms. And I would like also to say a few words about the need of anaerobic burden or some mixed burden. Exercise capacity is a very important aspect. And right now, for example, we're talking about the pleiotropic effect of exercise capacity. That means a healthy lifestyle, and usually such patients achieve much better results. To sum up, we wrote an article which was published in the 12th issue of Cardiology Journal last year. The key aspect is a comprehensive use of therapy. Meta-analyses have shown that each drug separately is good, but it doesn't allow us to achieve good results in most patients. Here you can see 3 types of drugs, and we can achieve a much better effect in this category of patients with ejection fraction from 55 to 64%. If it's higher, the effect is not achieved. Well, of course, we must understand why this is happening. If, for example, one sartan can lead to improvements and in other patients, not if it's just one empagliflozin, the picture is the same, but only combination of these drugs will allow us to achieve better results in most patients, at least in patients with this clinical phenotype, which overlap in many cases, and patients with hypertension. And of course, it's important to use a combination therapy. To sum up, you can see AHA, ACC recommendations of 2022. So we may not reduce mortality, but at least we can improve the situation, especially when we use alpha-glyphosine and ARNI, and also ARB, as you can see it here, and even sartans, well, can achieve good results, although there are some disputable issues here. On the basis of the international data, we participated in the development of a new version of Russian guidelines, and Yuri Mikhailovich at the last Congress, Russian National Congress of Cardiology, presented the results with alpha-glyphosine, how it can be used. The recommendation is 1A as far as empagliflozin is concerned, and of course, ARNI 2A on the basis of the Paragon study and our study. And also, you can see that we have conducted the sub-analysis and obtained these interesting results. To sum up, I would like to suggest you familiarize yourself with the article which was published in the latest edition of Cardiology Journal. There are answers to many questions there. Thank you very much once again for your attention. If there are any questions, please send them to our chat. And right now, I would like to give the floor to our next speaker, Professor Ovchinnikov, who will be talking about left atrium as the main driver of the heart failure with preserved ejection fraction. Please, Professor Ovchinnikov, the floor is yours. Let me share my screen. I hope you can see it now. Can you see my presentation? Thank you very much, Professor Gaev. Good morning, dear colleagues. In my presentation, I would like to focus my attention not on all heart chambers, but on the key chamber which is important for pathogenesis. That's the left atrium, and I will try to provide arguments to support my position. First of all, just some reference data. Heart failure with preserved ejection fraction, HFpEF, is a very serious disease. According to the American registry, among patients with HFpEF who were hospitalized due to the exacerbation of heart failure, the 5-year mortality counts to 75%. The risk of rehospitalization accounts to 84% during the 5-year period. The most important thing is that there is no class of drug in this type of heart failure that could increase life expectancy. And in many cases, this is due to the fact that we don't have a clear understanding of the mechanism of how heart failure with preserved ejection fraction develops. But we know for sure is that the hemodynamic structure of heart failure with preserved ejection fraction is an increase in the filling pressure. If we want to make this HFpEF diagnosis, we must identify an increase in the pressure in the left atrium, whether it's elevated or normal. It depends not on the diastolic function of the left ventricle, but on the condition of left atrium. Let's look at the left atrium in the context of the development of heart failure, natural development. Well, norm, physical exercise, when it's a normal situation, the situation of rest, the left atrium is being filled itself due to the process of active relaxation. But as soon as active relaxation process slows down, and such processes slow down in all patients with the cardiovascular disease, with some minor exceptions, the pumping becomes weak, and there is a need to push the blood on the side of the left atrium. And some patients for many years, in some patients for several decades, in some patients for the entire life, this means intensive contractility of the left ventricle. And this compensatory reaction can be as long as possible. It can be basically internal. And there is one but here. There are other forces that this heart pumping can be broken, and some patients, but not all patients. Well, all patients have, this relaxation, but only some have heart failure. So some of these patients, due to these detrimental forces, the heart pumping becomes weaker, the contractility of the left atrium weakens, and there is a threat of the filling of the left atrium, and the organism involves another compensatory reaction, that is the increase of the average pressure in left atrium. The left ventricle fills in more or less adequately, but at a high price. As soon as there is increased average pressure in the left atrium, the patient becomes in the category of the heart failure with preserved ejection fraction. But until the left atrium successfully performs its major function, the first function is adequate filling of the left ventricle, and the second function is also very important, that is prevention of this detrimental impact from the diastolic dysfunction of left ventricle to the pulmonary bed. When, for example, why the left atrium manages these two functions, there is no heart failure, and this bastion is one of the most reliable ones. But if the left atrium function is weakened, then the diastolic problem a problem develops. If this happens, this means remodeling, first into the pulmonary vein, then into pulmonary arteriolar, then into the right heart chamber, and there is the developed form of heart failure, and plus when there is the left atrium dysfunction. No matter how we increase the pressure, it is not enough to provide the minute output. As soon as there is the dysfunction of the left atrium, the patient has heart failure developed, in this case with the preserved ejection fraction. As soon as diastolic dysfunction progresses, especially of the left atrium, and an increase in the pressure of left atrium, there is an increase in the volume of left atrium, and that's a structural indicator, and the worsening of the function of the left atrium. As for volume, structure, and function, there is one major difference here. The higher the filling pressure, the higher the average pressure in the left atrium, the wider the left atrium becomes. And here, the worsening of the structure of the left atrium is the consequence of the filling pressure in the left atrium. But why the average pressure increased in the left atrium? The reason for that was the dysfunction of left atrium. And in case of this dysfunction, an increase in the average pressure is the compensatory reaction. In response to this dysfunction, the average pressure in the left atrium increases, and the severe the dysfunction is, the higher the pressure is going to be, and this pressure leads to the widening of the left atrium. So an increase in pressure in left atrium in patients with HFpEF leads to the dysfunction of the left atrium. In a normal condition, the left atrium thoroughly modulates the filling of the left ventricle. The left atrium does it due to its reservoir, piping, and contractility function. The reservoir function is performed during the systolic function. When the valve is closed, the blood goes into the chamber, then the mitral valve opens, and there is the conduit function of the left atrium being implemented. When blood from the pulmonary veins goes to the left ventricle, and there is a ventricular diastole, there may be a systole, so this pumping works right here. Out of these three functions, the reservoir function is of the most important one. The reservoir function depends on many events. It depends on the contractility of the left ventricle, on the contractility of the left atrium, on rigidity of left atrium. So these multiple dependencies lead to the situation when one of the problems here leads to the problems with the reservoir function. So this is a very sensitive marker. How can we assess all these left atrium functions? We can use speckle tracking method. Speckle tracking allows us to assess the contractility of the left atrium, and this particular indicator is shown here. That's the maximum amplitude of the ventricular systole. Well, so this indicator is very good because it indicates the pressure in the left atrium, and for example, in case of atrial fibrillation, in case of mitral ring calcinosis, and again, you can see this elasticity is very important factor. And there was a time when we showed that when the left atrium function is poor, when it's not normal, when we have asymptomatic heart. In this case, we can see that the situation changes and the patient develops HFrEF. So you can see here patients with HFrEF and comparison with asymptomatic patients. So what is meant? Patients with HFpEF, NT-proBNP is normal, while feeling pressure at rest is normal, but it increases with physical exercises. It turned out that these patients with hidden heart failure with preserved ejection fraction, the earlier problems occur, and these are functional problems on the part of the left atrium and the reduction of the reserve of the left atrium, that is the decrease of elasticity of the left atrium during physical exercise. So this lesser indicator in case of HFpEF was quite an important factor. It is associated with prognosis, the reduction of lesser by 1%, and the norm is more than 23%. A reduction by 1% leads to an increased risk of cardiovascular complications by 4%. The most important thing, and I have already mentioned that lesser is associated with the feeling left atrium pressure. And if this indicator is less than 18, in this case, it's 100% sure that the patient has increased average pressure, so left ventricle feeling pressure. So this indicator as for experts on diastolic function, they suggest it should be included in the modern algorithm to assess the severity of the diastolic dysfunction and feeling pressure. This year, there will be new recommendations published, and this lesser indicator will be part of this algorithm. At least it has already preliminary been included together with E/E apostrophe TR velocity, LA volume. So lesser will be used to assess the increased feeling pressure in the left ventricle or not. To sum up, well, the dysfunction of the left atrium is an epochal event that allows us to assess patients with HFpEF. Let's look at the mechanisms why this left atrium dysfunction occurs. In most patients with any cardiovascular disease, well, have slowed relaxation. The pressure in the left ventricle is reduced, and there is a systole in the left atrium. At rest or during physical exercises, relaxation stops, so the pressure in the left atrium is usually normal, and the pumping occurs when the situation is quite normal. But if slowed relaxation is accompanied by increased rigidity of myocardium, like fibrosis develops, in this case, well, the pressure in left ventricle increases with blood pumping, and the left ventricle pressure will be increased. So that means there will be more burden, but that's not the burden the left atrium cannot cope with. Yes, of course, if the pressure is very high, there will be a dysfunction. But if it's the moderate increase, the left atrium can cope with this pressure. But there is one but. The forces that lead to the situation when the left atrium cannot cope with the increased post burden, and there is a systolic dysfunction develops. And this mechanism of the left atrium dysfunction is called post-load dysfunction. That means that the contractility function of the left atrium is preserved, but they cannot contract against this high level of post-load, but they can restore contractility contractility when we reduce the burden on the left atrium. So we need to reduce the volume of post-load. And here you can see the major mechanism of the development of left atrium in patients with heart failure with preserved ejection fraction. This is the post-load discordance, and you can see the worsening of the left atrium occurs. And again, because of this dysfunction of the left atrium, or myopathy is proportional myopathy, when the chances for the restoration of left atrium are very high. But what forces have a negative impact on the left atrium? Microvascular inflammation is the main force. Microvascular inflammation, according to the modern concept, is the basis for progression of left ventricle dysfunction, but microvascular inflammation has an impact on left atrium. It violates the function of the left atrium, the slowing of the relaxation of left atrium fibrosis, to mention but a few. Experts also identify atrial fibrillation as another factor, and the primary damage to myocardium of the left atrium in case of myelioidosis. When the left atrium is damaged, the speed of dysfunction of left atrium are ahead of the speed of progression of the dysfunction of left atrium. Here we're talking about disproportional myopathy of left atrium. Naturally, there are no isolated or disproportionate myopathy. There is always a mix. The most important mechanism is post-load disjunction, but in some patients, the left atrium wall is involved, and proportional myopathy usually has the reversal character. It can be reversed, but when the left atrium wall is involved, in this case, the chance of the restoration of the left atrium wall are very minimal. So that's the irreversible process. So you can see proportional and disproportional myopathy. The ratio is 1:2 to 1. 2 cases of proportional means 1 case of proportional. How can we have a clear understanding whether the damage is reversible or irreversible? This can be done within a 15-second period if we use the methodologically correct Valsalva maneuver. And you can see that here we can reduce the pressure on the left atrium. And again, if we use the Valsalva strain, and this Valsalva maneuver helps us see if the pumping restores, then the dysfunction is reversible. But if there is pseudo-normalization occurs at rest and also at the peak of the Valsalva maneuver, that means the left atrium damage is irreversible. That's a severe damage. Most experts consider atrial fibrillation as a disproportional myopathy, although there are some parallelism with historical dysfunction. If we look at all HFrEF patients, it is quite clear that atrial fibrillation occurs when the severe of dysfunction is more significant. The severe the diastolic dysfunction is, the higher the probability of the development of contractility dysfunction of the left atrium. And that means that there is a need, the passive compensatory increase of the pressure in the left atrium. How can we do it? How can we increase this pressure? And theoretically, there should be 2 events. First of all, we should increase the preload on left heart chambers, like by narrowing the systemic veins. And second, we must increase the rigidity of the wall of the left atrium, so to launch fibrosis in this wall. Why do we need this? This is necessary because this preload increase on the left atrium due to the increase of the rigidity of the left atrium will lead to the exponential growth of pressure in the left atrium. That means there will be the adequate filling of the left atrium. The diastolic gradient of pressure will be increased between the left atrium and left ventricle. The organism can do it, but at a high price. At the price of the fibrosis of left atrium that may lead to arrhythmogenesis. That is why half of the patients with HFrEF have atrial fibrillation. And in conclusion of my presentation, I would like to discuss the question of the restoration of the left atrium function. As the chamber responsible for the development and progression of HFrEF, if we manage to restore the left atrium function, then many manifestations of heart failure, if not all, can be reduced or even disappear. And the major mechanism of the development of the left atrium dysfunction is this post-load disunion. As soon as we reduce this, our left atrium will restore its function. So to reduce the post-load on left atrium can be by hemodynamic discharge of the left atrium by administering loop diuretics, as we have shown before, and especially patients with HFrEF. And again, the diastolic dysfunction of the third degree proved it.
It was associated not only with clear reduction of the mean pressure in left atria, but this reduction of mean pressure in left atria in 70% of the patients was associated with the improvement of left ventricular filling. The type of filling was improved, but type of filling could be improved only due to one thing: recovery of the function of left atria. So please appreciate this example. So this is typical participant of our study. Initially, he had systolic dysfunction, restriction, and very high medial pressure in the left atria. Then completely killed left atria, and this is what happens 6 months later. This is classical relaxation and very good atrial pressing, so a little bit increased mean pressure in left atria. So they switch from restriction to the slow relaxation, from low pace A to high pace A, from poor contractility to high contractility of left atria. So it can be related to only one thing, with the recovery of the function of the left atria. As I said before, in our study, it happened almost in 70% of the patients, but in 30% of the patients, hemodynamic disloading of the left atria did not lead to the improvement of the type of filling of the left atria. So here we call these patients non-responders. When we compared them with responders, it appeared to be that these non-responders, they were not different from responders in their functional conditions of the left ventricle, and they were different from responders, and it was initially worse functional condition of the left atria. So these non-responders had mainly irreversible dysfunction of the left atria. Hemodynamic disloading of the left atria of left ventricle in these non-responders did not improve the type of filling, but was also associated with the reduction of the mean pressure in the left atria, maybe not so significant like in responders. That is why, if our hemodynamic disloading of the heart in the patients where there is no improvement of the type of filling of the left ventricle with this hemodynamical disloading of the heart, or patients with atrial flutter, then in these patients, hemodynamic disloading is also justified. But we should remember that in these patients, there is a high risk of development of the syndrome of non-sufficient filling of the left ventricle. Here on the left, what happens to the responders in the patients with the reversible dysfunction of left atria, when this dysfunction happens in the post-load separation? So with the reduction of the mean pressure on left atria, the filling of left ventricle from the high pressure of left atria goes to the recovering pumping of the heart, and the risk of syndrome of insufficient filling is coming to zero. And this is patient with atrial flutter. Here, the whole ventricle filling is based on the very high mean pressure in the left atria, and that's it. So when we remove this compensatory reaction due to the dynamic disload, should be done very cautiously, because if we are too aggressive with diuretics and if we reduce preload, so then we will have a high risk of the development of syndrome of insufficient filling. So what other ways exist for the decompression of left atria? One of the ways discussed here, this is reduced LAP HF2. This is sort of a bypass between left and right atria. So from high pressure compartment, it goes to the lower pressure compartment. And this is a special device. So it appeared to be, so it was clear from the very beginning that this device could be implanted only when there is pulmonary or vascular disease and there is no high pulmonary resistance, because this bypass of the blood from left to the right leads to the fact that the stroke volume of the right ventricle and the flow through the pulmonary artery is increased by 25%. And it can have critical and even catastrophic consequence for the patients with higher cardiac pulmonary resistance. So this device can be implanted in only normal resistance level, and it appeared to be that device is not safe even with patients with latent cardiac pulmonary disease, when in rest the resistance is normal, but then increased in case of physical exercise, as it has been shown in the reduced lab heart failure 2 study, where the device was assessed prognostically for the implementation, and that would be shown as the fact of growth of resistance in the physical exercise, and then implantation of this device worsened the prognosis of such patients. And 2/3 of the patients they did not have the latent disease, and for them implantation of the device was associated with improvement of prognosis. We look for criteria, search for the optimal patients. This device should be implanted not for everyone. I'm coming to the end. This is chronic disease, and using statins. The use of statins of patients with the heart failure with preserved ejection fraction improves due to the recovery of the function of left atria and the reserve of left atria. And flatter arrhythmia. So flatter is no contractility, and the recovery of sinus rhythm is recovery of the contractility function of left atria. This is Cabana study. So it appeared to be that in patients with have PAF recovery of sinus rhythm with ablation leads to the lower relapse rate and also improves the prognosis. And then the basic points for my presentation. Dysfunction of the left atrium increases the filling pressure for left ventricle and increases the risks of involvement of the right chambers of the heart and progression of the heart failure. The best way to assess left atrium is the assess of myocardial deformity. So this is lesser. This is the most important measure to control is hemodynamic decompression using diuretics of the bypass. Also, hypertension belongs to statins, aldosterone antagonists, and catheter ablation in the latter, but all that should be required in the large randomized trials. Thank you very much for your attention. Thank you very much. Very interesting, and we have already some questions, but we'll have dedicated Q&A time. And now we give the floor to our last speaker, and this is Professor Lopatin. Distinguished colleagues, dear Professor Avdeyev, dear Professor Ovchinnikov, it's my pleasure to listen to your presentations, and it was really a true pleasure because it gives the description of the modern status quo of the situation with HFpEF, but at the same time, we set a very important practical question to create clinical guidelines, to update guidelines on how we will provide medical care to the patients with HFpEF. But today, I would like to draw attention our patients and our colleagues whether we can treat patients with heart failure for the whole spectrum of ejection fraction in the left ventricle. And this is one of the hot topics for the discussion. So here you can appreciate the following. Ejection fraction is a very important parameter because this is how we classified heart failure. Here you see European and American guidelines here, and we wanted to offer a very different cutoff were offered for the ejection fraction, but nevertheless, in the 21st century, we see synchronization of understanding of experts in Europe and also in America and in other professional communities. There is some difference only with American colleagues. For example, they frequently use such parameter like heart failure with improved ejection fraction, which we don't. For us, it's important to classify the phenotypes, which are shown here. You know these phenotypes very well. For HFpEF specifically, we need ejection fraction here, and also structural or functional deterioration, increased filling pressure of the left ventricle, and increased level of NT-proBNP. BNP. And actually, there is no big discussion. What for? Why? But let's compare. These are guidelines of 2016 and 2021, and this is moderately reduced ejection fraction. Do you think it's important, 40-49 or 41-49? It matters. We mentioned 41-49 as a moderately reduced ejection fraction, but this is an analysis which was demonstrated by Professor Lars Lund, and he showed that a very big percentage of the patients could have 40%. And if we are guided by the previous guidelines, we can classify these patients both as a moderately reduced or reduced ejection fraction. But the problem here is, yes, truly, we can identify very clearly, let's say, true heart failure with reduced, with preserved or moderately preserved, but there is some more variability in terms of measuring of ejection fraction, and there could be the error in measuring. And then it's a very practical question: what should be the protocol of treatment when we assess our patients with heart failure, and which parameters require very precise analysis? Dear colleagues, just think it over, and I hope you agree with me. First two presentations were brilliant, and they demonstrated how deep we should dive when we assess HFpEF. Here you see a very famous diagnostic algorithm in heart failure. In fact, our work is focused on the following. Besides the identification of medical history, physical exercise, measuring of NT-proBNP, we also performed echocardiography study to get the answer to what group our patient belongs to: low ejection fraction 40% or moderately reduced or preserved. Definitely, it would be very good, ideally, to identify etiology of heart failure as it is in order to select adequate treatment. It's not accidentally, dear colleagues. If we speak about the algorithm of patient management with heart failure, well, for the first time, when we started talking about the treatment of patients with heart failure with reduced ejection fraction, now we have 4-component scheme of treatment, which we frequently call quadrotherapy, together with diuretics as an obligatory option for the management of patients with heart failure. And here the evidence-based level was immediately 10A, and this is very clear because this is one study and one meta-analysis, but nevertheless, there is another option, dear colleagues, another option. And the situation is related to the fact that heart failure can be characterized by the switch of one ejection fraction to the other, worsening or improving. And that is why intermediate ejection fraction, and these are specialists from Singapore, Solomon from the United States, they call it, let's say, middle child. And this is clear ideology. So a lot of attention to the older child, a lot of love to the youngest child, but the middle child is getting nothing. Well, speaking about the most important characteristics, it's very important characteristic because the percentage of patients they switch from one fraction to the other is pretty high, even in the context of moving from moderately reduced to preserved. And this is exactly the topic of our discussion, or let's say the reverse journey. Once again, before the European guidelines, where there was an idea to select this moderate ejection fraction, and the arguments are still ongoing. Do we need it? Do we need it or not? We use classes of treatment that were working with the patients with reduced ejection fraction. We use the same classes. And in 2021, European experts told us very clearly, it's better to call it moderately reduced ejection fraction, moderately reduced, because we see the effect from treatment, which is used for HFrEF. And I emphasize it once again, treatment is very similar by itself, very similar. And there are some other ideas now. Let's split heart failure to low, less than 50, and preserved, let's say, higher than 50%. But then there is counter arguments in other specialists who are dealing with devices, and they mentioned ejection fraction as a parameter that we need to be guided by when we identify the indications for the treatment. And here are some data. This is all groups of patients and all groups of treatment, mineralocorticoid receptors, beta blockers, sartans, and there are no special studies for them, all guidelines based on post hoc and group analysis, and that's it. And the point here is that the first impression here about the heart failure with preserved ejection fraction is opportunity of the fact that we have capacity to modify the course of the disease and we can improve the outcomes. But all that was actually disregarded by neurohumoral modulators assessment. That's a very important question. But then sometime later, we see that in the moderately reduced ejection fraction, we have some more data that require some attention. As inhibitors, mineralocorticoid receptors antagonists are needed. So we launched the process to go beyond 40% as a cutoff that proves the improvement of the prognosis. And in 2021, it was quite a surprise. But this chart was published, level of evidence 2B for all these classes of treatments and expert position. Experts offered to use it in this category of patients. But the paradox here, and here you see the main results of the Emperor Preserved study shown here. When we present European guidelines in 2021, and they said that we have no drugs that could modify the course of the disease. And Professor Avdeyev already emphasized that. So 90 minutes later, when they saw the results of Emperor Preserved, it is very clear that they need to change this section of the guidelines. Now the work is ongoing. European experts are trying to update the current guidelines, and the first news will come in May 2023. And the final news at European Congress on Cardiology, because you should not skip that. The reduction of cardiovascular event risks, such as cardiovascular death or heart failure hospitalization minus 21%, it deserves our attention. And another one, again, SGLT2 inhibitors, and specifically empagliflozin, demonstrates very early effects for the reduction of the risk. And that is why I'm showing you the design of this study, because the group that has been working in this direction quite consciously included patients with ejection fraction higher than 40. And this is very important because, in fact, there is an overlap when we get these positive results. And the group with moderately reduced and preserved groups are shown here. In this study, 2/3 of the patients had half-PEF, preserved ejection fraction. It was 50% or higher. And when they analyzed how it was demonstrated by SGLT2 inhibitor empagliflozin in patients with moderately reduced and preserved ejection fraction, the deviation of the curves is very obvious. Risk reduction for the cardiovascular events is very important due to the hospitalization, due to the heart failure. And this is a very important aspect on what is the clear driver of these results. It is obvious, this joint analysis, and you see these results on the screen. Now they talk a lot about the normal or even supernormal ejection fraction, giving the explanation to the specificity of this group, because this is quite specific etiology of the disease, let's say amyloidosis or hypertrophic cardiomyopathy. But fact is a fact. In our country last year, there is indication to treat heart failure for the first time, adult patients with heart failure, regardless the ejection fraction. So no matter whether there is diabetes or not, but it reduces the risks of cardiovascular mortality and heart failure hospitalization. It reduces endpoints. Luckily, next year, and that would be 2022, we get the results of DELIVER, and we see the same results. And we see very good splitting of the curves with dapagliflozin. Risk reduction is 18%. And the number of patients that we need to treat is 32%. Is it important? Yes, of course, it is important. When we consider these two studies, we should say immediately the phrase that the information we received is additive, and it gives us more information, more knowledge that now we can effectively treat heart failure with preserved ejection fraction. Here, I would identify the categories of patients that were studied in DELIVER category, the group with improved ejection fraction. To us, it's also a very important phenomenon. We need to understand that we can improve ejection fraction, and what should be recommendations here for the further patient management, even if the ejection fraction is actually having preserved ejection fraction. As you can see here, dear colleagues, the drug demonstrated brilliant results in all ejection fractions. In the situation whether there was recent decompensation or not, that led to hospitalization in heart failure. And this is a very good work. And this is improved ejection fraction, or it is preserved ejection fraction. Per se, it is very clear that the investigators immediately do the joint analysis of the DELIVER results with dapagliflozin and preserved with empagliflozin. Now we have the class of treatment that reduces cardiovascular mortality and hospitalization because of heart failure, as well as in separate components of this primary endpoint. What happened, dear colleagues? Now, in our disposal, we have two independent studies and no meta-analysis, and a meta-analysis that gives us evidence-based class 1A. And once again, about the ejection fraction, even in the level of ejection fraction higher than 60%, these analyses show a reduction by 19%, the primary endpoint, with a high level of significance. And here we need the reaction. And here on the screen, you see very famous specialists from the UK. This is Teresa MacDonald. And she was commenting the results of the study. And she said, as soon as she became aware of the results of the study with dapagliflozin, and this is the DELIVER study, we have evidence-based treatments for the treatment of patients with moderately reduced and preserved ejection fraction. So these data are additive to empagliflozin data, and they say that there is no need to stop the treatment, but we should just continue because it improves the prognosis in our category of patients. So guided by the massive data, we can say that risk mortality reduction, reducing risk of worsening of the heart failure and improvement of the clinical symptoms could be obtained with this class of treatments regardless of the ejection fraction. And this is a miracle. We see the whole spectrum of options, and we discuss them to be used in any ejection fraction. We see not only SGLT2 inhibitors, but also SARTANs, ARNIs, antagonists of mineralocorticoid receptors, and becomes very clear that the analysis that actually was carried out first in the moderately reduced, but truly less than 45%, less than 40%, less than 35%, or let's say high levels of ejection fraction, no matter. Actually, in the clinical trials, the thresholds of ejection fraction were different, but when we see positive data in one of the first data that was obtained specifically for the condosartan in the moderately reduced ejection fraction, and we can get positive result here. And now we relaunch the discussion on the fact that we have evidence-based data related to the use of mineralocorticoid receptor antagonists, MRIs, or ARNIs. And this is another representation of European guidelines. FDA experts supported the idea to use in heart failure patients with HFpEF the MRI, mineralocorticoid receptor antagonist spironolactone, and this is TOPCAT study. Also, very active discussion here about the role of beta adrenal blockers. And if you pay attention here, dear colleagues, this is a whole number of endpoints like overall mortality, hospitalizations, and cardiovascular mortality. And here we see the efficacy of how this class of treatments works. That's another situation with HFpEF. And then it appeared to be very interesting. It is very interesting. If we demonstrate efficacy of valsartan sacubitril in different levels of ejection fraction 57%, this is file showed or lower, guarantees the effect of treatment that actually meets particular category of patients who are having HFpEF. What happened at the end? So this is another slide which was presented by Teresa MacDonald. TBD, to be discussed. So the idea here that we cannot miss any longer the fact that we have very good opportunity to modify the course of the disease, regardless of the ejection fraction. So this is very reasonable to expect that the level of evidence and class of evidence could be the highest to us. And to us, this is level 1A. And this is not accidentally that Russian experts and actually big role was done by was played by the group of Professor Abdeev. So it looks very, very attractive. What is also interesting, that's 2022, before the results of DELIVER. American experts publish their own version of the guidelines. So in the green quadrants here, they say how we should treat our patients with reduced ejection fraction. And this is classical 4-component scheme that include RAS blockers, beta adrenal blockers, antagonists of mineralocorticoid receptors, SGLT2 inhibitors, etc. But what American colleagues emphasize in their recommendations, let me emphasize it once again, before DELIVER study, we see here that SGLT2 inhibitors, they have, let's say, more convincing data in the guidelines versus other classes, but it does not mean that we should work just with this class of treatment. Of course not. There is proper place for ARNI, for MRIs, and for SARTANs. And we wait just a little when the document would be presented about particular phenotypes from the point of treatment in patients with HFpEF, heart failure with preserved ejection fraction. Very soon it will be published, and hopefully it will happen by the end of May. And now we have new opportunities. Please appreciate pharmacological treatment of our patients mainly could be considered not in the context of ejection fraction, but in the context of results, the outcomes we can when we manage the patients with a very different levels of ejection fraction. With that, I thank you very much for your attention and for the honor giving me to make this presentation. And then I'm happy to participate in the discussion. Thank you very much for brilliant presentation of data. Well, I have to say the symposium is extremely interesting. So we surprisingly spoke about the left artery and now ejection fraction. So, and we have some more questions in the chat. And if possible, please open the chat and check the questions. Check the questions, please. And if possible, I would like to ask first question to myself. Probably I will take it. So in American guidelines on the heart failure, so the question about HFpEF, so what they recommend ARNI and sartans, where the ACE inhibitors? Well, good questions, good questions. Where are ACE inhibitors? Where are ACE inhibitors? Because American guidelines that we're referring and you paid attention to, it has been already shown based on the studies that they give green light or yellow light or red light to different classes of treatments. And let me draw your attention that both ARNI and angiotensin receptor blockers are not number one. So gliflozins are on the first position. Gliflozins. Speaking about ACE inhibitors, they're not gone. They're not gone. But there were no studies with these treatments like with sartans and with ARNI in order to speak conveniently. I think Pepsi Check was in 2020 quite long ago, but not very convincing data on perindopril, and that's it. And that's it. So I'm sorry, but ACE inhibitors are not in this block. Second questions, patients with obesity, hypertension, and shortness of breath. Sometimes they give have a ref without pro-BNP, tissue Doppler and valvular pathology. Can we reduce the diagnosis before the confirmation? Well, cardiologists, they are prone, especially in the outpatient centers, to put HFrEF immediately without extra studies. In 2015, a CHF register was published, which was carried out by the lead of Professor Terещенко and others. And actually, they discussed this type of phenotype when the fraction is higher than 50%. I think 83% of cases, this is hyperdiagnosis, of course, of course. So let me put it this way. To make the diagnosis here is not correct because we don't have evidence of the key thing, the dynamic of the most important hemodynamical constant, filling pressure. Sooner or later, directly or indirectly, we have to answer the question whether filling pressure is increased or not, higher than particular threshold. And that is why we have more convenient European and American algorithms where we have 6 parameters. You give answers, you get points. And if it's more than 6, for example, or let's say more than 7, then you can confidently say that HFrEF is here. But what you mentioned here, it is not enough to speak conveniently about the increased feeling of pressure. So shortly answering, no, not correct. But about the diagnosis of CHF, let's wait for the publication of Russian guidelines, and hopefully we will be able to put all the dots over the I's, and we will mention the stages of CHF, and then it would become very clear. Next question, and I think, yes, this is question to Dr. Ovsyannikov. Now the question, if there is dilation of left atria, and as a result, paroxysmal form of flatter, which treatments could be used to minimize left atria, to reduce left atria size? Well, partially I tried to answer this question during my presentation. Our task is try to reduce the load for left atria, that's first, and also to remove hazardous factors. And first of all, to remove chronic smoldering inflammation. And here, the best and the most powerful antifibrotic treatment is aldosterone antagonist. That's very good. Also, one of the most powerful anti-inflammatory treatments is statin. That's why to this patient, I would administer aldosterone antagonist with statins. And also to such patient, I would administer triple combination because gliflozins and euperioarni, they have anti-inflammatory and also antifibrotic effect. Speaking about diuretics in such patients, well, Of course, it is not easy to dilate left atria. It's dilated not simply when we increase the atria in the left atria, but when it's more or less continuously increased. So if it's a continuous increase of the pressure in left atria, that means we have a relatively strong diastolic dysfunction. And in such case, if we see a rather strong diastolic dysfunction, so that means diastolic dysfunction of grade 2, grade 3, that means pseudo-normalization or restriction, then to such patients as a must, I would administer supporting dose of diuretics to restrain and to control preload to the left atria. Thank you very much. Yes, another question is also to you, dear Dr. Ovchinnikov. In case of dilation of left atria without a CHF with preserved ejection fraction, can loop diuretics be started at the start of treatment? Well, left atria dilation most frequently happens because of the middle pressure in atria, and this is a hemodynamic basis of heart failure. And there is no situation where left atria is dilated without the features of heart failure. I can give you only one example, when there is dilation of left atria, but there is no heart failure. And this is mitral failure. So left atria could become very large, but if it's a very severe mitral failure, then it would be not heart failure. But if we have dilation of left atria, so please look for heart failure, HFpEF specifically, HFpEF with preserved ejection fraction. But if there is no feature of HFpEF, but there is dilation of left atria, then probably I would not start loop diuretics. I would wait for heart failure to come. I would wait for pseudo-normalization and restriction to come. And if you don't wait for that, so at this stage, please consider the option to administer very good anti-inflammatory treatment, which is statin, for example, Believe me, this patient, if you assess these patients from the risk of cardiovascular complications, most probably this patient would have the high or very high risk, and statins are needed in any case. Unfortunately, our patients, especially with HFpEF, who are indicated statins, but half of them are not taking statins. Thank you very much, Artyom. Yes, that's quite brave declaration. Definitely, it's not yet accepted. Well, I was providing my own position. Well, okay, very good, Yuri. Please appreciate. I think next question 5 is to you. What to select, DAPA or EMPA, and criteria of selection? Well, as the question is very practical, so we split patients, ejection fraction less than 40, then you can take both. If currently we make a decision to manage patients with HFpEF, then we should select EMPA because it is written in the label. And very soon, we hope that the same indications would be seen in the DAPA label. And again, these two categories go hand in hand. This is not the issue of contraindication, but desire to administer these two treatments to patients with heart failure. Because actually 2-3 years we speak about great class of treatments, and we know what is the rate of administration in the real practice. And being serious, we need to work. But if your patient has diabetes type 2, then definitely you would consider the selection of this treatment in the context of the fact that these drugs are indicated for the management of patients with diabetes with heart failure. So please be guided by the existing label and existing indications. Thank you very much. Thank you very much. Let me add here, and I totally agree with you that unfortunately yet, even with low ejection fraction, where gliflozins are obvious. So the data of Prioritet study, which is ongoing now, they say 16% totally, 16% of cases where patients were recommended gliflozins. So probably we even shouldn't contradict, but actually to increase our efforts to stick to the label. Yes, Yuri, can I ask another question now? That's about group of treatment which are playing the leading role here. About chambers of the heart. Great question, great question. I think this is very deep question because we number of drugs that have anti-remodeling effect, what we can use to minimize the chambers of the heart. I think methodology is interesting, how to get evidence-based data, because it's always when we assess particular organ protection, we should compare drugs in between each other to say that whether it's one leading or maybe the second one is taking the leading position, if there is head-to-head comparison. And let's recollect earlier studies for the regression of left ventricular myocardial regression. So there was a task to compare the treatments, and the assessment of the results of echocardiography should be done in the centralized lab and better by 2 or 3 independent experts. The class of treatment is working very well if we speak about ARNI, and also we speak about other RAS blockers and also SGLT2 inhibitors, so also great effect on the remodeling effect and a number of other treatments. Speaking about the leadership, it could be a long discussion, but in formal logic, we should not collide treatments in between. So another question. So questions related to official guidelines, because we have quality assessment of treatment, quality assessment. So the question is how frequently we should measure the chamber size and the left ventricular thickness in patients with HFrEF and HFpEF. So about the quality assessment, how frequently we should control the remodeling in the patients? Yes, very serious question. And let's thank our colleague for asking this question. Let me start from the beginning. After the discussion of the project of guidelines, where we have special section of HFpEF, and it was done by your leadership, Professor Avdeev, we also had another meeting, Committee on the Clinical Guidelines, and we are expecting that maximum by June 1st, the document would be already presented at the website. And I would be here happy that this question also would be asked later on when we have this discussion, because the rate of echocardiography assessment, could be more frequent or less frequent. But again, we need to have expert consensus here. We need to approve it from echocardiography colleagues, because actually they have some loads, etc., etc. We should not go into the organizational stuff, but the important thing here is we need to assess the dynamics and to do it quite regularly. And there is no question about it, because we can take stable patients and we can take, okay, let's take it once a year. Or maybe if we face a patient that gives us clinical manifestation, we can increase the examination rate and to do it very fast. I'm not speaking about the standard echocardiography protocol. I'm speaking about the assessment about left ventricular filling pressure and more detailed assessment of left atrial function. This is exactly what Artyom's speaking about. Well, great question, but still in the new version of guidelines that we are preparing, do we have such section of the quality criteria and echocardiography and its rate? Is it mentioned there? Quality assessment is there, but the echocardiography rate is not there. The need of echo, yes, and there is no doubt about it, but let's say the frequency of echocardiography and also frequency of measuring BNP is not recommended yet. There are 9 criteria for the quality assessment. Okay, I totally agree with you that we need to discuss it and we need to put it into the guidelines, that's for sure. And there are some more questions about colchicine. I know that you love colchicine and you are dealing with colchicine. So what do you think? Well, I skipped the question about ARNI. It is very clear we spoke about it. So now question 9 about colchicine. So we have 10 more minutes to answer all the questions, so we can easily proceed. So colchicine. Why not? Why not? If we are guided by the fact that the main problem here in the progression of diastolic dysfunction, this is chronic and smoldering inflammation, and there is no way to improve, really improve the survival in these patients, we have to look at anakinra study, with very powerful interleukin blocker, IL-1 blocker, anakinra, and it showed, well, all in all, good results. Then our results with anti-inflammatory statins, they showed also very good results. And by the way, it is statins, other treatments, where a meta-analysis proved the capacity to improve the survival of patients with heart failure with preserved ejection fraction. Speaking about colchicine, this is also very interesting, and I know that currently in the United States there is a clinical study ongoing to assess colchicine to the hemodynamics and the manifestation of patients with HFpEF, and possibly there would be very good effect here, Well, the question is, do we have any data on colchicine in heart failure, or shall we wait for the end of American project? Let's wait for the end of American project. Yes, I have a short comment here. Well, if it would be easy to, let's say, put the fraction from reduced one and then to the one that leads to fibrosis, there are many studies that are showing that all these mechanisms could be in all the patients. And then it's different interpretation on how we assess our patients, and what you showed today, Artyom, about left atria specifically. That's very interesting direction, not only from the point of science, but also in the practice. In colchicine, we showed improvement of functional class and parameters of systolic function, but in order to make the drug to be in the guidelines, well, here we need a very large study with very clear endpoints. At least we're expecting that in 2024 this study will come, and there is another study which is ongoing, but even with the positive results, and then we can put it into the update, and the results should be as positive as, let's say, SGLT2 inhibitors. Yes, absolutely. As a remark, I would give you that possibly they mean that these inflammations, and this is guiding for us, and it is very clear that inflammation is clear in all stages, and we know that to use anti-inflammatory treatments with a low ejection fraction. So anti-inflammatory treatment right now is having sort of a second breath now. We have another question, Artyom, to you. So I think you can take them. Question 13 specifically, what should be if we see diastolic dysfunction type 1 in patients with arterial hypertension without it, with a normal size of left atria, and whether CHF could be made as a diagnosis or not? Well, it appeared to be that the most frequent type of filling of left ventricle in patients with heart failure with preserved ejection fraction is diastolic dysfunction of type 1 with reduced relaxation. It is seen in 50 to 60% of the patients. And what does it mean, slow down relaxation in rest? That means the pressure is normal. And if you suspect in your patient's heart failure, well, for example, shortness of breath of unknown genesis, and you suspect that this is cardiac, but the filling pressure is normal, that means diastolic dysfunction grade 1, then most probably it would be normal level of NT-proBNP. And in such situations, it is recommended to perform diastolic stress test. And during this test, we should track the dynamics of filling of left ventricle pressure, filling pressure. And this is E prime and tricuspidal regurgitation, because it reflects the pressure in the pulmonary artery. And I strongly recommend you to look at the methodology, how this diastolic stress test can be carried out in the special consensus document of the experts that was published at the end of 2020 in Cardiology Journal. Thank you very much. If I understand it the right way, the most important thing is the increased filling pressure at rest or at physical exercise. Yes. So whether we're answering this question, we can answer when we are sure, or if we see what is the filling pressure there, directly or indirectly. And another question to you, I know you have this experience and this knowledge. What is the rate of switch from HFrEF HFpEF to HFrEF to HFrEF. So that's interesting when the fraction is considered to be the longitudinal parameter. So that's one disease with different trajectories. Well, the answer to this question is the proof that these are still different forms of heart failure. And there is no clear switch from one to the other, from HFpEF to HFrEF. Why? Because as statistics shows, as our own experience shows, the rate of switch of patients with HFpEF to HFrEF, let's say patients with hypertonic heart. So that's ideal model of HFpEF. So that's very low switch rate for 8 years. Among 200 patients, we saw such switch in 7% of the patients. So these are single cases, and mainly it was related to the flatter arrhythmias development. In all these questions, systolic dysfunction was minimal. So actually it was in the interim of 40 to 50%. So that's very important. So factors of transfer could be these transforming issues like ACS or MI, and there the switch is obvious. It's obvious. So Yuri, if you don't mind, let me refer to you. Now the question about colchicine, another question 10. So this is HFrEF. Only inhibitors from RAS blockers, sartans are not effective anymore. So that's a question. I think they missed what they were talking about. Well, dear colleagues, I can tell only one thing: sartans keep their efficacy. And this is a phrase in the guidelines. Only if ACE inhibitors are intolerant or ARNI is not intolerant. So if you see the patient with intolerance of both, then you have to administer sartans, and that's it. So please, colleagues, read guidelines and make the markings. Another question: why doctors do not administer, let's say, complete treatments? So the question about compliance, why do you think? Well, traditionally, we have 3 groups of participants: patient, then healthcare professional, and the system, healthcare system itself. And each of the stakeholders have particular arguments that facilitate non-prescription. If you take a patient, low compliance or intolerance to treatment or contraindications to treatment. If you take healthcare professional, that's therapeutical inertia. You take healthcare system, then some cost-related issues are involved. And at the last meeting of American College, for example, they also had political component included. So the point here is not to discuss the politics, but let's say real limitations in reality that can happen due to particular conditions. So in fact, we have many challenges. We work together quite a lot. So please recollect when there was the first idea to train the patients what to do with the heart failure and what we did as a society of specialists. For 10 years ago, mainly, we need to understand that we have to prepare patients properly because actually it's a new update and there are massive recommendations, a lot of and we have to give particular knowledge now. And there are achievements that should be done. And this is not easy work to itself, but we have to do it. So we have 2 more minutes, So very briefly, and by the way, number of questions is really huge. So that means there is big interest to that. Speaking about digoxin in HFpEF, yes, I will answer yes, especially in the situation of fibrillations. And digoxin would be working very nicely. But the deep study showed that digoxin probably is not the option that is pathogenetically effective in this form of heart failure. And now a few words, Yuri, to you mainly. Patients with moderately reduced ejection fraction, and they have more heterogeneous characteristics. Why? Why do you think? The higher is the ejection fraction, the higher is heterogeneity that reaches maximum in the HFpEF. From the practical point of view, it would be very easy to split, let's say, a low fraction and preserved fraction. But let me repeat once again, it's important to understand that then we close the chance to make decision in case of implantation of different devices. In fact, it can be intermediate position in between two fractions, this group with devices, and that is why it is called moderately reduced. And this is a motivation to assess neurohumoral modulators. And we say that in this subgroup of patients, we can get very good results. And the experts believe that let's move towards HFrEF mainly, but all is in the details. So we can find this phenotype where we see a number of features which are typical for the low ejection fraction and simultaneously for the preserved ejection fraction. So every time we have to keep in mind individual approach. Well, dear colleagues, I have an apology to make, but the time for Q&A is depleted. We have many questions, and I promise that every question would be answered. With that, thank you very much for your participation, in the symposia. Many thanks to Professor Lopatin, Professor Ovchinnikov, because they spoke about very challenging issues, sometimes not frequently discussed. So hopefully the time of this symposium was very useful and interesting. Thank you very much. Have a good day and goodbye. Goodbye.